therapies for older adults with and without dementias. So we help develop predictive models to see factors that lead to good and bad outcomes for older adults. And here are the objectives for today's talk. By the end of this talk, hopefully you'll all be able to identify potentially inappropriate medications for older adults with mentation and mobility issues, and apply a deprescribing framework to different patient cases. So in our medical school curriculum in the United States, according to the LCME, which is our accreditation body, typically there's about 120 to 180 hours in most U.S. medical school undergraduate curriculums. But with increasing awareness of importance of polypharmacy, institutions are really starting to talk about updating curricula to include explicit instruction on deprescribing. So typically it's 1 to 2 hours in most medical schools. Sadly, that's the way for us too. We get about 2 hours in deprescribing and how to stop medications. So I think this is an opportunity for growth across all medical schools and all curricula worldwide. I'll have a couple questions in here. Feel free to put your answer in the chat. What would you consider is the definition of polypharmacy? Please feel free to answer in the chat. I think the chat's a great place for us to make this a little bit more interactive. What would you say the definition of polypharmacy is? Option A, 5 or more medicines. Oh, A's a popular pick. And I think I would say the correct answer is actually E, because there's really no consensus about this. But I really say we know that the risk of harm really starts to go up when in drug-drug interactions above 5. But sometimes polypharmacy might just be somebody who's taking aspirin. That might be potentially inappropriate. If somebody has a history of hemorrhagic stroke and they're on aspirin, that's probably polypharmacy. So I would say there's no consensus definition. When you look at numbers, most of you were correct, though, when you say, if you look at raw numbers, it's often described as greater than 5 medications for most patients. I think the phrase I want to use is inappropriate frequently. The phrase inappropriate referring to more medications than is actually medically necessary. And there's a lot of potential harm from polypharmacy. We know that there's drug-drug interactions. We have competing enzymes in our cytochrome P450 system. We have drugs that are renally cleared when people have chronic kidney disease. We have changes in volume of distribution with older adults, sarcopenia, body fat percentage. All of these factors lead to changes in risk for adverse drug reactions in older adults. Adherence or compliance becomes more difficult with more medications. It's harder to swallow more pills, and it's harder to keep track. It's more difficult to keep track of a higher number of pills to take. Falls are often common side effect of inappropriate medications. Cognitive impairment or cognitive issues, delirium, loss of functional status, and cost. These pills are not free. They cost money, and they contribute to overall health system cost or individual cost. I'm going to turn off. I have a space heater here. It's only 1 or 2 degrees Celsius here in Cleveland, Ohio. So I'm going to turn off my heater here. It's getting a little hot. Okay. Please feel free to add in the chat. What percentage of hospital admissions in older adults might be thought to be caused by medication-related adverse events? This is U.S. data. U.S. hospitalizations thought to be caused by medication adverse events. Got option C here, D. Okay, very good. Dr. Dharma Dasa. D, 10 to 30% is our data. It ranges depending on what source you're looking at, but it's the numbers of medication related adverse events are quite high. In the United States, adverse medical effect is the sixth leading cause of death, according to the Institute of Medicine. There's a lot of harm that happens by a health system that is not designed to do a medication reconciliation. So deprescribing, this is a definition from JAMA Internal Medicine, the systemic process of identifying and discontinuing drugs in instances where existing or potential harms outweigh the benefits in the context of the individual patient's care goals, value, functional status, life expectancy, and preferences. So deprescribing is the process of weighing the risk and the benefits and focusing on the person. I'm going to go through a process, and the purpose of this session is to go through a process or a formal approach to deprescribing, a 5-step pattern that you could follow with any of your patients. And this is something that could be applicable for any situation and any medication or supplement. So the first step is to verify the medications. A good medication reconciliation history. It is so common that the medical record is incorrect, and the advent of electronic health records have worsened this problem. Our pharmacies are recording medication lists. Hospitals record medication lists. Doctors have medication lists. Patients have medication lists. And all of them might be different from what the person is actually taking. So I think the first step is to find out who is managing the medications. Is it the patient that you're speaking with, or is it a family member or a caregiver, a neighbor? And so I really try and identify how the meds are being managed before you talk about the actual medicines or medical conditions. I ask my patients to bring their pills with them in a bag. So sometimes people have lots of bottles of supplements or pills from many different doctors. And I've seen patients in the United Arab Emirates, which might have a similar situation to where you're seeing patients who have bottles that might have multiple different languages on them, and the patients might not speak the language on the bottle, the pill bottle. So that makes the medication reconciliation especially difficult and challenging. But the MedRec is the foundation of everything. The medication fill history, if you're able to contact the pharmacies that patients use, I try to encourage my patients to go to one pharmacy for all of their medications or pills. It makes it easier to identify drug error or duplicate medications. I ask about over-the-counter medications that are non-prescription, what medications patients are buying that they are taking that they are not prescribed by a doctor. Supplements or vitamins, natural medicines are important. Topicals, patches, eye drops, inhalers, substances like alcohol or stimulants, caffeine. These are all medications because they all have interplay or interactions with other meds that might be prescribed. So after you've verified the medications and had an accurate list, that's the hardest part, getting a list of the medicines and the list of the supplements that's accurate is very difficult. But once you have done that, then I think things actually start to get easier. So considering the overall risk of medications, so some resources that I think are very helpful, the American Geriatric Society publishes the Beers criteria every couple of years. It's updated every 3 or 4 years, where we look through common adverse effects and drug side effects, drug interactions for older adults. These are ways that medicines are often differently metabolized or uniquely unique side effect profile that's more common for older adults. So, for example, anticholinergic effects, cognitive effects from anticholinergics, or from benzodiazepines or sedative hypnotics. We use Lexicomp is a software that we use to look up, you can look up volume of distribution, pharmacokinetics, pharmacogenomics. What are the cytochrome P450 enzymes involved? Is there a substrate to CYP2D6? Is it a inhibitor or is it a universal inducer like rifampin? Um, we also use a different database called the Natural Medicines database, but it's important to know that supplements that people take are medicines, and many of them will interact with your cytochrome P450 system. So your pharmacology is very dependent on drug metabolism and what drugs might be competing with the same enzymes. So using a natural medicines database or and looking at resources like Lexicomp or I even like Wikipedia has the P450 enzymes involved in different drugs. Once you know the different enzymes involved in your patient's profile, it can be an opportunity to identify potentially inappropriate medications. And these are some common medications that we see that contribute to falls risk in older adults, cognitive impairment or delirium. Common evil medicines that are hanging over our heads, the anticholinergics, antipsychotics, benzodiazepines, steroids or sedative hypnotics, or the Z drugs like zolpidem or eplerenone. Which of the following do not have strong anticholinergic properties? These are generic drug names. Please feel free to add in the chat. Well, the correct answer here is actually E, mirabegron. And I think a lot of people don't always realize that so diphenhydramine, strongly anticholinergic. Paroxetine. Paroxetine's an SSRI, also strongly anticholinergic. I think a lot of people don't realize paroxetine, commonly given for older adults for mood disorders. Meclizine, used for dizziness, antiemetic, strong anticholinergic properties. Trospium, used for incontinence. Systemic anticholinergic properties can affect cognition. And then amitriptyline and our tricyclic antidepressants in older adults, often potentially higher risk for side effects. It doesn't mean you can't give them to older adults, but it means that there's a higher risk to discuss. The next step after we've considered the overall risk of medications would be to look at what meds we want to, just what meds are eligible to deprescribe. I think it's very important to discuss eligible medications with the patient and family. And it's really important to talk about what matters most. This is the 4M framework of age-friendly health systems. This is a program that is developed by the Institute for Healthcare Improvement to improve how hospitals and healthcare systems can focus on or reprioritize care away from the disease-centric problem list and going through every problem as separate siloed conditions and looking at an overall framework for the care for older adults. So the most important thing is what matters most. What matters most to your patient? What's most important to the family? Family-centered decision-making is very important, and more important when you're dependent on that family for supportive care for the older adult. And knowing who is managing these medications is very important, and where the trust is from the patient. Is there a generalist who is helping to coordinate the care? And that's the real benefit of comprehensive primary care or having a general internal medicine, family medicine physician overseeing medications. but then also trying to recognize where the specialists are and the values of different conditions to the patient and what's most important to how they feel. So when we look at what matters most and identifying medications and seeing how they affect mobility, function, mentation, quality of life, it helps us to identify and prioritize what matters most to the patient. So prioritizing now is the next step. So how to prioritize our medications for deprescribing. So looking at medications with the greatest harm and the least benefit. So pills with a low likelihood of withdrawal reactions or disease rebound. I think it's really helpful to, those are your low-hanging fruit. So if you see meds that are not going to cause disease rebound, but have high side effect profile, those are easier medications to come off of. And then talk to about the patient about, are they willing to do this? Are you willing to come off of this medication? And then come up with a plan and monitor it. So ensuring everyone is on the same page. Number one, it goes back to the medication reconciliation. Make sure that list is correct. Update the list. When you see a patient's med is inappropriate or you're stopping a medication, make sure you change the med list to update it. And make sure the family, the patient, and any other buddy involved, any other physicians involved in care plan understands what you're doing. It's very easy when you have like an integrated health system where you can send messages or email to all the providers and make sure all of the places the patient receives care will have the med list updated. That's why having one pharmacy is easier to make this happen. One pharmacy, one source for all medications for your patient. If you have that trust with the patient to go to one pharmacy, it makes it easier to avoid inappropriate prescribing. And then monitoring for adverse effects. What's the plan to watch out for? What symptoms should they watch out for? Warning the patient about potential withdrawal or adverse effects from deprescribing will help to establish trust in this process. So we'll just go through, again, this is the 5-step approach that we described: verifying medications, considering the risk overall of the medications, assessing individual medications for eligibility, prioritizing what's the easiest or most important or pressing medications to deprescribe, and then implementing a plan and monitoring. There's a lot of barriers to this. People have a psychological connection with their medications. They feel emotional about medications they've been on for years. They treat the medication or the pill like another family member. Risk of adverse withdrawal. So if you're stopping a patient's sedative hypnotic sleep medication, knowing that there might be some rebound or some irritability at nighttime or difficulty falling asleep might be something to warn a patient about, and then come up with a new, safer approach. Time. It takes time to talk about these things, and it takes time to talk to family. It takes time to update the medication list. We don't always have time because we have a lot of patients to care for. The turf war, the confusion over the discipline or specialty. Who should be making the call on the statin? Should cardiology be calling the shots on the statin? Or is it okay for a generalist or a geriatrician to step in and say, this pill might have risks that outweigh the benefits at this time for you? So I think that's important to say, who should be making these decisions? And then lack of evidence. There's not a lot of research on coming off of pills. There's not a lot of money in it. The drug companies are very, very much in favor of more pills and more medications. It's how they make money. It's how they make money off our systems, off our countries, off our patients. So there's sometimes a lack of evidence and lack of research on how to come off of medications. So I want to describe the Deprescribing Consortium comes from our colleagues in geriatric and family medicine in Canada. The Canadians started funding deprescribing research almost 20 years ago. It started with proton pump inhibitors like omeprazole and esomeprazole and lansoprazole, pantoprazole. The Canadian gastroenterologists and the Canadian family physicians recognized skyrocketing rates of PPI prescribing in the mid 2000s. And this led to a multidisciplinary effort across the country to identify what the causes and triggers were for PPI overprescribing. And they created an algorithm for PPIs to approach with your patients, starting with why is your patient on the PPI? And then to come through a process of what the indications are for continued PPI use and what the reasons are to maybe deprescribe the PPI. And they came up with an approach. And as you can see, this is not a one-stop shop. This they start by saying decrease to a lower dose. So if a patient's on 40 of omeprazole BID, they recommend to reduce the dose. So maybe go from 40 twice a day to 40 once a day. And then to monitor the patient at 4 and 12 weeks to check in with that patient, and then reduce the dose again, potentially after 4 or another 8 weeks. Patients might have rebound heartburn. They might have some dyspepsia. And so it's important to warn for that and to watch for that with safer options like timing of meals or making sure patients elevate the head of the bed and not to eat right before bedtime, and managing symptoms with safer alternatives like calcium carbonate or H2 and H2 blockers, receptor antagonists like ranitidine. So I think this whole process takes time. It's a lot harder to get a patient off of a high dose of a PPI than it is to just write a new script for a higher dose or to just refill the medication. Their website where they go through, they've now since the PPI success that the Canadian physicians and gastroenterologists and family physicians had about 10 to 15 years ago, they created a website, deprescribing.org. They created a whole open source collaboration on deprescribing algorithms for different drug classes. And every few years they release a new drug class so they now have drug deprescribing algorithms for sedative hypnotics, cholinesterase inhibitors, NMDA antagonists, antipsychotics, benzodiazepines, lipid lowering treatments, sulfonylureas, and insulin. So some outstanding opportunities to learn some algorithms to apply to your patient care. I'll go through some cases. These are all patients that I took care of in the clinic. This is an 80-year-old female who established care. She has an extensive past medical history. Epilepsy, a seizure basically documented after a stroke in 2003. She has had multiple ischemic strokes, but only one seizure, which was when she was hospitalized with an ischemic event. She has chronic kidney disease and stage 4 peripheral arterial disease, status post-stenting, falls, anemia, GERD. Also more falls in the last week, sleeping a lot more lately, feeling dizzy at times. Her values are she's full coach. She wants everything to be done to optimize her care. So here's the medication list. Now, please look at this, everybody, and she's dealing with some dizziness. Things to stand out on her medication list include she's on aspirin, clopidogrel, so dual antiplatelet therapy, and atorvastatin. She's on Depakote because she had seizures after a stroke in 2003. She's on ferrous sulfate, 324 milligrams TID, receiving iron 3 times a day. Hydralazine, enalapril, chlorthalidone. This is a really extensive list. She has normal iron now. Her TIBC is 302, Transtat 23, ferritin 93. Depakote level is 30. Her valproic acid level is 30. Um, Here's her B12. Here's her vitals. If you can see, she is orthostatic. Um, any opportunities, please engage in the chat. Do you see any opportunities here for potential deprescribing or medications that might be eligible to discuss? Are there any medications here that look like they might be an opportunity for? Please use the chat. Any of these medications? Chlorthalidone? Yeah, she's orthostatic. Absolutely. Yeah, so maybe backing off of one of the antihypertensive medications might be appropriate. Typically for older adults, hydralazine is a higher risk medication than chlorthalidone. Chlorthalidone is a thiazide-like diuretic, may have mortality benefit, whereas an enalapril is usually a safer medication. Probably hydralazine is the higher risk of the antihypertensive drugs. But that's good thinking to go right for the antihypertensive drugs, especially TID, hydralazine. That's a pretty high dose for an older patient. Atorvastatin, absolutely. The atorvastatin might be inappropriate. She does have an extensive stroke history. She's 80. Her lag time to benefit, probably around 3 years for the atorvastatin, 2 to 3 years for the atorvastatin. So for life expectancy, it probably for her, I continued the atorvastatin, but it's definitely something to consider. Aspirin, yeah, I think either the aspirin or clopidogrel, potentially. There's more research showing that clopidogrel is an antiplatelet therapy for someone who has had a number of strokes. Should probably be on some antiplatelet therapy, but whether or not it's aspirin or clopidogrel, it seems like the risk of aspirin um, might be outweighed by the benefit of clopidogrel might be a better approach. So probably only one of the antiplatelets. Yeah, and so these are some of the other medications that I included here. The over-the-counter fish oil, there's very little evidence about fish oil supplements. The iron, absolutely. 3 times a day iron, it's insane. Um, our ileum can only absorb so much iron. For most older adults, every other day dosing is probably appropriate for iron deficiency anemia, but her iron is normal. Her iron count is normal. Her transferrin saturation is normal. Her ferritin is normal. I would stop the iron altogether, and we did. B12, her B12 levels were super therapeutic, 1800. So these were the meds. And Depakote. She had one seizure after a stroke in 2003. That was 22 years ago. And I saw this patient 2 years ago in clinic is when this case happened. I would stop the Depakote, stop the valproic acid. I think anti-epileptic drugs are often overprescribed long-term with little evidence for need, especially if there's a trigger. This isn't a patient with epilepsy. This is a patient who had a seizure with a stroke. So 22 years later, not necessary. Patient number 2. This is a 62-year-old female or 66-year-old female who was referred to me for concerns of cognitive impairment and polypharmacy. She has a diagnosis of, she has neuropathy. She has adenocarcinoma of her right lung. She's had bilateral PEs, COPD, asthma, osteoarthritis, GERD, constipation, osteopenia, incontinence, MASH, or metabolic associated steatohepatosis, I think is the new term now, no longer NASH or NAFLD. We call it metabolic now, MASH, hypertension, seasonal allergies. She complains she's on too many medications. She wants us to do what we can to improve her function and quality of life. That's her goal. This is her medication list. And this was hard to get. Look at all of these pills. So many medications. Highlights here, we have gabapentin and lidocaine, diphenhydramine, fluoxetine, bupropion, losartan, amitriptyline, rivaroxaban, osimertinib, aspirin, oxybutynin, topiramate, calcium, cholecalciferol, senna, omeprazole, meloxicam, naproxen. I'm using all generic names here. Albuterol, budesonide, formoterol. That's a lot of medicines. Is that more than five? I think we're more than 10. I think we're approaching 20. This is crazy. There are so many meds and supplements. This poor lady, this poor lady eating pills for breakfast, lunch, dinner. How does she have room for any nutrition? Her MoCA score, the Montreal Cognitive Assessment, which is a screening tool we use, which is impaired. Her geriatric depression scale, we use the geriatric depression scale short form. Yes, no questions, which is validated depression screen for older adults with cognitive impairment. And both of these are in many different languages, including Tamil. I don't know about Sinhalese, um, but these are validated across different demographics and different and different languages. Blood pressure, heart rate, BMI 33, and then this is her. Oh, it is in Sinhalese. Okay, I did not know that. I did not know that. It's not on my list. So that's I have like when I tried to look at South Asian mocha on our Cleveland Clinic list, it had Tamil, it had Hindi, it didn't have Sinhalese. So okay, thank you. That's very good to know. Um, so and all these labs were all within normal limits. So let's go back to this list of what are potentially inappropriate medications here that you might include. Well, we know a lot of her vitamin scores, her calcium and vitamin D are in within normal limits. Her B12 is normal limits. So I think the osteopenia meds here, the calcium, cholecalciferol, potentially inappropriate. I'm not saying they are. Incontinence, oxybutynin. This should be a red flag. Oxybutynin it always has horns. Some demon medicine here sometimes. Oxybutynin. While it can really fix the dry up a patient's incontinence, it can very much have cognitive effects. Amitriptyline, we spoke earlier about anticholinergic medications. Amitriptyline, highly anticholinergic. Um, Diphenhydramine. She's also on aspirin and rivaroxaban. And she's on meloxicam and naproxen. She's on two NSAIDs. Oh my gosh. Two NSAIDs? It's crazy. This is the list of meds that I thought was potentially inappropriate. Diphenhydramine, losartan, because her blood pressure was, very well controlled. Probiotic. She has enough medicines on her plate. She doesn't need a probiotic, multivitamin. We know amitriptyline is anticholinergic, oxybutynin anticholinergic. Topiramate, she's been losing weight. She's frail. She's lightheaded. She's having cognitive issues. She doesn't need to lose more weight. She's even though her BMI is dropped, from 33, was it to 33 to 29? Omeprazole PPI, this is potentially inappropriate. She's not having active GERD symptoms. Get it off. Use that algorithm we talked about from the Canadians. Naproxen and or meloxicam. She's got two NSAIDs on board and high blood pressure and history of ulcers and GERD. Like this could be causing her to need the PPI and aspirin. I mean, this is a prime example of where you could have the pharmacologic cascade. You take a pill to treat the side effect of another pill to treat the side effect of another pill. High dose NSAIDs absolutely could be contributing to her need for the PPI. And this high dose NSAIDs might be contributing to the need for the antihypertensive drugs. So I think there's a wonderful opportunities to deprescribe here. This is an inpatient case, a patient I saw admitted to the hospital for a hip fracture. The orthopedic surgeons, I was a resident, they called and they asked for geriatrics to review the patient's care prior to surgery to help optimize him for surgery. And we're very fortunate to work with our surgeons, our surgical colleagues, that when they see patients that are potentially high risk for surgery, that they involve geriatric medicine to better optimize care, to promote better surgical outcomes. I think it's a really important collaborative approach to surgery, that surgery doesn't happen in a silo, that patients appropriate for surgery are optimized. So here, this 85-year-old male was admitted to the hospital for a hip fracture. He had high blood pressure, type 2 diabetes on non-insulin dependent. A1C was 8.5. He has osteoarthritis, mild dementia, CKD3, history of prostate cancer. Talking to him, he felt really tired. He kept falling asleep in the visit. He's in the hospital bed and he has a broken hip and he's still falling asleep. These are the meds. Diphenhydramine as needed for allergies. Sertraline, lisinopril, metoprolol, succinate, nifedipine for hypertension. So he's on an ACE inhibitor, a beta blocker, and a calcium channel blocker, SSRI, and an antihistamine. He doesn't take any supplements. Well, that's good. That's one less thing to think about. Insomnia, he takes melatonin prescribed, which could be a supplement depending on how you view it. He was diagnosed with mild dementia recently and started donepezil about a month ago, was prescribed about a month ago. For primary prevention of heart attack or stroke, he has aspirin. For GERD, he's on omeprazole. For osteoarthritis, he takes acetaminophen. He has prostate cancer in remission, but takes Lupron hormonal therapy, and which is anti-androgenic hormonal therapy. I think Lupron might be a brand name. I don't know the generic name. Tamsulosin and metformin. So here's his rhythm strip on telemetry. So gentleman's passing out, falling, break his hip. And this is the rhythm strip. He's in complete heart block. He's in AV dysynchrony. So potentially inappropriate meds. Well, for him, we have the nifedipine. We know that. We know the metoprolol. So we've really beta blocked him with metoprolol. He has a calcium channel blocker, nifedipine. But then there's also donepezil. Donepezil has beta blockade effects in some individuals. And so we're using it to treat his dementia, but it can induce complete heart block and can induce bradycardia in older adults. It's a small percentage, but it's a potential risk. And so for this patient, donepezil on top of nifedipine and metoprolol triggered him to be in complete heart block. And in further history taking, the donepezil had been started 7 days prior. Actually, they started taking it 7 days prior. It was prescribed a month before, but he didn't start taking the pills until a week before. And then baby aspirin, absolutely. He's 85. He doesn't need an aspirin if he's for primary prevention of heart attack or stroke risk. The PPI omeprazole might contribute to osteopenia or osteoporosis and might be inappropriate if he doesn't need it anymore. And the diphenhydramine can make him sleepy. Diphenhydramine can make you fall. So I think diphenhydramine is a potential inappropriate medication here. So the takeaway points I have is deprescribing framework, having a process of going through these drugs allows for optimizing medication regimen in older adults. I'm going to go back to my slide just so we have this reference point of, because I really think the take home point is that 5-step approach towards deprescribing. And I'm happy to, I would love to take any questions or perspective or feedback on places you've seen this applicable in your clinical environment or with your patients. I'm very excited to hear all of the great things that have been that the University of Colombo's, offering to older adults in Sri Lanka and all the great potential and possibility with our rapidly aging population in Southeast Asia, in South Asia.
Thank you very much, Dr. Kansia. That was a very excellent talk and very clear. I think it's very relevant to our context. I was just wondering how similar our patients are. And one of the very catchy statement was like the patients having this emotional, contact with their medicines, especially their vitamins and, PPI, and how well we can relate to the same scenarios. Like you have to really get their family on board when this prescribing process starts. It's very, very relevant. And we have a very diverse audience, starting from a professor of pharmacology as well. Professor Priyadarshini Kalapati is here, and she's one of my teachers. And thank you very much, madam, for joining. And Professor Deshani Disanayak, a neurophysiologist, and she's also part of our center. And thank you very much for staying throughout. And all our students and trainees who have joined as well. That's why I said it's a very wide array of audience. And please feel free to ask any questions. And you can unmute yourself, raise your hand, put it in our chat box, and please make maximum use of this opportunity to discuss. And I know some of the medicines you may not, have come across yet in your practice, and but we'll go to the questions. Thank you so much, Dr. Kansi. Yeah, there are a lot of thank yous, and yes, madam, I can see. Yes, Professor Gala.
Oh, yes.
Yes.
Yeah, thank you very much, I think, for that very excellent talk on covering on the prescribing. I think this is one of the very areas I mentioned. I happen to be the professor of pharmacology, so we see this is something that we also really focusing on. Many of our patients are on multiple medicines. In fact, one study showed that those who are over 60 years, they are on, on average, they have polypharmacy on 8 or more medicines are given to those patients. Fortunately, I think the use of I think antidepressants are not as uh, common as in the West. So I think that is probably a better thing that we note here, because many of our patients are living with their extended family, not in I mean in nursing homes and so on. But I also want to ask you, actually, one thing that we were trying to develop is getting our pharmacists to pay attention to deprescribing, attention to polypharmacy when they note it, and try and limit whatever the medicines as much as possible. We try to get medication reconciliation done, because with the WHO Global Patient Safety Challenge on medication without harm, this is also one of the key focus areas. So my question is, how often do you use the Beers criteria for identifying the potentially inappropriate medicines, or do you use any other particular checklist to identify, or is it based on just looking at the prescription that the patient is having, and considering which one can be discontinued, or are you using any checklist or any particular criteria? Thank you. Over.
Yes, no, that's an outstanding question. So, number one, first of all, I share an office with a pharmacist. I have
Okay.
so I'm very lucky because we work together to care for my patients. I have a
Mm-hmm.
pharmacist who sees many of the same patients I see. And so my
Mm-hmm.
visits are often my patients will see me for 30 minutes or 60 minutes, and then they'll see the pharmacist for another 30-minute visit. And she can do further medication
Mm-hmm.
education,
Mm-hmm.
and she will outreach with the pharmacies. In the United States, we have retail pharmacies that are businesses and private companies that don't share health records and they don't share health information. So there's a huge gap in the medication reconciliation. That's the hardest part. And then the potential inappropriate lists. Oh, the pharmacies usually don't do that where people in the United States where people are picking up their meds.
Mm-hmm.
Our electronic health records um, we have our pharmacists review the Beers criteria and start and stop, as well
Mm-hmm.
as other potential drug interactions from CYP enzymes or contraindicated conditions like history of Stevens-Johnson syndrome with certain medications or allergies. And so our medical record, will put stops in place or hard stops or red flag warnings for certain prescriptions. So for us, we are becoming overly reliant on the electronic health record or the computer to tell us and warn us and catch this. But we need to think
Mm-hmm.
ourselves. We need to think when
Mm-hmm.
we write the prescription or when we take it off or when we do the
Mm-hmm.
medication reconciliation. I review the Beers criteria myself with our students. That is my
Mm-hmm.
primary list that I go through for potential inappropriate medications. We really want to start and stop is another excellent approach to take. I
Mm-hmm.
don't use start and stop every day, but I read about start and stop, and I think it's probably some of the tools or approaches from stop are probably involved in this deprescribing framework, that I'm describing
Mm-hmm.
here with you today.
Mm-hmm.
I really think it's important though for students to use these resources because this is how no matter what specialty they go into or what type of care environment, if it's a specialty, if it's general medicine, primary care, or even surgical care, recognizing these medications are different for older adults and the effects are different is very important. But really I wish the pharmacies on the back end would call out some of this stuff. I had a patient who was receiving 3 statins from 3 different pharmacies, and he was emotional. This was in
Mm-hmm.
California. I was in San Francisco. We had a lot of Chinese American patients, Chinese immigrants
Mm-hmm.
in California. He speaks Cantonese. He went to a Cantonese speaking doctor who gave him a statin. He was a veteran, so he also had medicine from the veteran hospital, and then he had a
Mm-hmm.
primary care doctor in his community, and all 3 were prescribing statins, and nobody knew that each other were prescribing it. So he was taking 3 statins. I think this is the kind of stuff that if we had a better way to communicate among pharmacies, that we could identify these duplicates.
Yeah, most certainly. I think we also see the situation. I mean, using two NSAIDs is a common scenario, and continuation of dual antiplatelets beyond 1 year after, say, for example, acute coronary event or something like that, where they should be discontinued. We often see. So I think most of the problems that you highlighted, we are also seeing here as well. And one of our main challenges is that we do not have much time to spend with the patient because our clinics are very heavy, and a doctor will have to see a lot more patients than what would happen, say, for example, in the US or UK, or and therefore very little time. So that's one of the key factors which promote non medication reconciliation. We are trying to actually include medication reconciliation as one of the steps that they should attempt. Particularly, we have actually tried not in just in polypharmacy, but excessive polypharmacy, where more than 10 medicines are there, so that you focus on some of the patients who are on lots more medicines than just five or six, because many might need five or six if they are having multimorbidity. But it's a challenge, and I think somewhere an area where we will need to work on in Sri Lanka as well. Thank you.
Do you have a lot of patients that might see a public doc or then see different docs who don't have they don't know the other docs writing the same different scripts?
Yeah, very common, very common. I would think that it is probably much more common here than anywhere else because we don't have a proper referral system. It doesn't operate through a normal GP refers to a relevant consultant. So any person can go to any state sector hospital as well as to any consultant in the private sector. So I mean, one patient might be under the care of four or five people, and they may not tell also that they are being followed up by somebody else. So unless you specifically ask, you will not know the patient, what the patient is getting from another consultant. Yeah.
So really the getting the med list is the most difficult part for you too. It's my hardest part. I think we did a study of patients discharged from Cleveland Clinic and to a rehab
Mhm.
facility for post-acute care. 70% had errors in the medication list. 70%. 70%
Mhm.
from Cleveland Clinic. 70% had a bad list,
Mhm.
had an error in the med rec. I
Mhm.
can't I don't know how. I mean, this is like it seems so simple, but just getting
Mhm.
the list of the beds, that one data point makes such a big impact for everybody assuming care after discharge.
Thank you for sharing that statistic. I think uh, it's very shocking as well as something all of us should be very well aware of. I'm so glad that the students have joined as well, and the postgraduate trainees in geriatric medicine who have joined like are sensitized to these topics, and they are seeing in that angle. And but the medical students, because they're learning about so many things, and this is probably universal. It's not geriatric medicine only. Yes, Professor Deshanit Disanaike, I'm so glad for your support in organizing this event as well. And she's a neurophysiologist and from our department. Do you have something to say?
I just want to thank Dr. Konya for that excellent lecture. I think all who joined benefited. And I think, as Professor Vajra said, deprescribing is not something that we focus a lot on, but it's happening everywhere now, even at home. With our parents, also, we see that happening, and we are reluctant to change the prescription, even though we are into medical fields. So, as you said, it's because of this lack of centralized care. Uh, the same patient will go to different specialties. And there'll be a lot of the patient will be looked at in the perspective of the illness or the effect on that system, and that system will be looked at. And then once the person together, you have a lot of medicines that the person has to carry around. So I think now, as Praskita also said, it looks universal. We thought it's happening here mainly because we have private sector, state sector, lack of communication between the two sectors, and the patients having their freedom and autonomy to go to anybody they like to go to, discontinue whenever they need it. But it's everywhere, it seems. And I think it's important that we focus on having one place where they'll be looked at. And I think when it comes to aging and geriatric population, it is more common than young people. So I think Chamila is trying to do that through the center to have a place where we can provide some guidance and centralized care. And I think you'll be a brilliant addition and an asset to that center as a person to collaborate with. So thank you so much.
Thank you very much, Tejashani. Are there any other questions? I think Haridu is one of the students had asked a question. I'm sure all the others could see the answer as well regarding multivitamins. It's a common culprit, and we do have this emotional connection with the multivitamins. We don't want to let go. And if there are any other questions from anybody else, please feel free to ask. And in the absence of any questions, I would then like to again thank Dr. Kanzia for his time, and especially on the first thing on a Monday morning and start of a week, spending time with us and educating our audience. And we'll be sharing this recording with the students, and Professor Vajir Disanaika just let me know also how wonderful this talk is. He's unable to stay. He could not stay till the end because of his prior commitments, and he want to for our students, especially the final year students who are preparing for exams, especially to hear about this concept, because they are the budding doctors who has to carry this message forward. And thank you very much for allowing us to share your talk as well. And we hope to continue the collaborations and keep in touch. Thank you so much for your time. And we will send the formal thank you letter in due course. Thank you so much.
Thank you. It was a privilege to present with you all. Thank you for letting me spend some time with you. Have a good night.
Thank you so much.
Thank you.
Thank you.
Thank you.
Have a good day.
Thank
And
you. Bye.
take
Yes,
care.
for you it's a good day. Yes.
Thank you so much.